All right, welcome to Doc Talk Live from the Matthews Art Center here in Spearfish. Thank you to everyone joining us in person and those listening online. Today we're going to talk about something that affects people of all ages, bunions, flat feet, and ankle pain. So whether you're on your feet all day, active in sports, hiking in the Black Hills, or just notice changes as you age, foot and ankle pain can significantly impact your quality of life. So with us today, Dr. Colin Zdenek. He's a fellowship-trained foot and ankle specialist at Spearfish Clinic, North 10th Street, who specializes in diagnosing and treating conditions of the foot and ankle, from common issues like bunions to complex injuries and total ankle replacements. So Dr. Zdenek, thank you for being here with us live at the Matthews Art Center.
Yeah. Can you hear me okay? All right. Thanks, everybody, for coming out. Just going to talk about a few things, a few different topics that I routinely see in my clinic. So since you guys came here, if you guys have anything you'd like to talk about first, if you've had any previous surgeries or know somebody or have like specific questions, keep it completely informal. So please feel free to interrupt and ask questions. So is there anything like specific that anyone would like to talk about? So I can talk forever on any topic that deals with the foot and ankle, unfortunately. So do you guys have any things you would like to discuss, any deformities or anything that you currently have or would like to talk about? Don't be shy. Arthritis? Particularly in a certain spot of the foot or the ankle, or just like in general, how do you treat that?
More the foot and ankle.
Yeah, okay. What's that?
Choices if you don't want to do
Surgery. Steroid injections, yeah. So I think probably what I'll do with that one, since that kind of fits into a lot of the topics that we'll talk about, I can kind of speak on that, because that's a tough one. Treating arthritis is a tough one. There's a lot of other things, modalities you can do to help treat it, so I'll probably just start off with going with that. So I think the first thing we'll talk about is bunions and kind of talk about the arthritis with that too. So anybody got a bunion? Yeah, I'm getting older and I can see mine kind of turning in a little bit too. So I think the first thing we can talk about is just the etiologies and like how bunions happen and who they occur in. So in my practice, I've seen bunions in kids and older patients. And so a lot of people ask, like, do shoes cause the bunion deformities? But typically, what I found is that a lot of people, you can blame it on particularly like an aunt or uncle or grandma, grandpa that you didn't like and blame it on them. That's how you got the bunion. So, but a lot of kids can have bunion deformities and adults too. And so the etiology and how kind of bunions develop is that if you look at the big toe, and I do have foot models here. So if you look at the big toe joint, basically what we're looking at is this bone right here will kind of start sticking out. And then a lot of people think they grow extra bone on the side of that joint, but really what happens is that metatarsal is this long bone right here. When that happens, that bone will actually kick out and it will rotate as well. So you're not growing bone, it's just that the joint is being exposed, and so the toe will come back in. So a lot of the times with that, I actually see a lot of patients with just mild bunions where it's not a large bunion, but it hurts them a lot because as that toe rotates, there's actually a nerve that's right there that ends a lot. It kind of pushes up on the nerve and causes a lot of nerve pain. And then with that too, a lot of people can get swelling with certain activities with it. So I tell all of my patients with any kind of deformity, even, everything that we're going to be talking about with flat feet and ankle pain. So a lot of people can get flare-ups with these types of deformities. Most flare-ups will go away. I even have like a Taylor's bunion. Basically, it's the bunion on the fifth metatarsal. So you can get flare-ups where it's red, hot, swollen. A lot of times it can happen with like activity if you're hiking or playing pickleball, which is pretty common. So a lot of those that you just need to slow down, ice it, decrease your activity. And I think the hardest part with foot problems, particularly bunions as well, is that it hurts every step that you take, and it's hard to stay off of it. So people try to cut back their activity. Icing will help with it, anti-inflammatories, but the hardest part is finding the right shoe. And I think that's a hard thing to tell people is what type of shoe gear to get, because a lot of times I stopped giving advice on buy this certain brand because shoes nowadays are $250, and I tell a patient to buy a $250 pair of shoes and it doesn't help, and I get yelled at, and so I try to avoid that. But biggest thing for bunions is finding a comfortable shoe, whether it's a really supportive shoe or it's kind of a flimsier shoe like a lot of people like Hey Dudes or Crocs. As long as your pain is going away, I would keep wearing that. And then don't underestimate the icing with it. So icing, topical pain relievers can help a lot of the times too. The problem with the bunions A lot of people will try to wear splints, and actually can help with the pain and the soft tissue. The problem is the splints and everything won't correct the deformity. So once you take that splint off, the goal is to get rid of the pain. So a lot of people want to wear the splints to correct it, but typically right when you get the splint off, your bunion deformity is still back. So going on from there, there is more kind of invasive things that you can do. There are steroid injections you can try. In addition to that, people will try to do the steroid injections, but the injection kind of takes a few days to kind of kick in, and sometimes it doesn't work at all. And then these flare-ups that continue throughout your life, sometimes you have a bad month, pain completely goes away. And I tell my patients too is, if you do get that pain to go away and you have the deformity, you don't have to fix it, you don't have to address it, you just kind of keep living on with your life. And then if it ever does kind of reoccur, you can kind of readdress it the same way. So times to come in is when the pain continues and it doesn't improve. That's when we'll get some x-rays, sometimes we'll get MRIs, and then there is a time for surgery with it. And there are like newer techniques that you can do with bunion surgeries. Typically the protocol for that, and I always tell people, the time to get surgery, because I try to talk people out of surgery because I don't want it either, but the time to get surgery is when you stop doing the things you enjoy doing that you should be able to do for someone your age. So if you want to go for a walk with your spouse and you go walk for, like a mile a day, you should be able to do that for as long as you live, but if you're out running 100 miles a day and you have pain, I would say probably cut that in half and see if you get better. So any questions about surgery or any aspect of that, or any other conservative treatment options for bunions? Or
so can you touch on why it happens? Like, is there a way to avoid it? Like, do you need to put the yoga toes between your toes every night? I mean,
yeah, so
is it just a natural aging process?
Yeah, a lot of people will say, like, are the shoes that I wear that cause the bunion deformities? But a lot of times the biggest issue with it is hypermobility. So when those joints kind of give out, the bone kind of takes the weight of your body and it splays out. And so that's how it develops. So a lot of it isn't wearing a certain shoe causes a bunion. Unfortunately, wearing high heels and stuff like that, that's why it's a little bit more common in women. Shoe gear can actually make it worse, but it doesn't give you the bunion deformity. Typically, it's inherited. A lot of it is genetic, and then the other one, too, is just the hypermobility that you see where those joints really want to kick out.
Okay.
Yeah.
So, like, when we talked about the veins with Dr. Nick, he said it was becoming more common because of our lifestyle, our overweight. Is that contribute to those as well? Yeah,
I think some of that too, and especially in older populations, they're so active nowadays too. I think pickleball is a big one. People are becoming a lot more being more active with it. The problem is, dude, now I'm almost 42 and I'm getting some foot pain. You can feel it. So I think it's a lot of people have issues with their feet, and it's a big deal because it slows you down from your job and doing activities that you want to enjoy. So the hard part with that is, I think with increase in activity, you got to be more cognizant of taking care of your feet, because wanting to play pickleball and do those things, I mean, that definitely adds to it, and people are a little bit more physically active, running long distance and later in life too, and so all of that kind of plays a role in it. Yeah, it's a great question.
Have the surgeries changed?
Yeah. Yep. So a lot of the surgeries, there's different techniques. There's over like 100 different types of surgeries for bunions. And so it's actually changed quite a bit. We have newer techniques that I've been doing. They're minimally invasive. So they're smaller incisions. And a lot of times we can fix it with these small incisions on the side of the bump. So you do shave off the bunion on the side, and we can do small incisions where we can actually put plates and screws inside of the bone, so it's not so prominent on the skin. And the benefit of it is that a lot of these surgeries back in the day, we used to keep people off their feet to recover from surgery. Now I get all my patients walking in the first day in a boot. Yeah. So there's different types. Some people, and that's the problem, there's not, you can talk to a family member or a friend, and they said, I had bunion surgery, I had this bunion, and they told me all I could do is this. But the problem with it, there's different types of deformities. Some people have just a bunion, and some people have a bunion with arthritis. And so that you have to address both of those at the same time. So everyone's a little bit different, but the techniques, they're changing in terms like fixating, because I'm sure you've heard a lot of kind of rumors too, like, oh, my bunion came back. And unfortunately that does happen, but the newer techniques are kind of helping to prevent that a little bit more. Yeah. Any other questions on that one?
My brother-in-law had part of his toe taken off, and that solved his bunion. Is that anything? And he had a sore on that toe.
Well, like the toe next to it, or?
The toe next to it,
Yeah.
and the top half removed. And he said, it was great. Do that.
A lot of, I have done that. A lot of the times is that that would be more held for like my older patients, you know, they're in their early 90s, and where if they do get a wound, again, there's so many different ways to address it. And so, you know, if you're 90 years old and you have a wound on your toe, the last thing you want to do is a big reconstructive surgery. So it sounds barbaric, but sometimes that is an option of just amputating. Removing it. I try not to do that, obviously, but the biggest thing is you don't want somebody to get an infection and get sick from that. So, but yeah, in younger populations, but I try to avoid that, but that's more so for people who aren't good surgical candidates. Yeah. So in terms of like conservative treatment for the bunions, finding the right shoe, make sure that it's wide enough for you. A lot of the shoes now, tying the shoes, bending over, yeah, hide those pretty shoes there, right? So mesh shoes are really good. So again, if you got to pay attention to the seams, sometimes the seams of the shoe can push on the bunion and cause pain. So experiment with different types of shoes, but having like a mesh on the side actually helps release some of the pain. And some of those like silicone spacers and braces, they do temporarily kind of relieve the pain. So if you can get just that acute pain to go away, then kind of go on from there. So, yeah. Any other questions about bunions? No? Okay. Well, we can probably, if we want, I'll probably talk about the ankle arthritis a little bit too. That's a big one. I think with ankle arthritis, there's so many things that can cause arthritis. Big one is trauma, so a lot of ankle fractures can happen. Excuse me. And with ankle fractures, a lot of times we tell our patients there's a risk of post-traumatic arthritis. And so anytime you break your ankle, you can damage some of the cartilage, and it's really tough to kind of regrow that cartilage, and so you get scar tissue there. And so, sorry about that. So ankle fractures, there's a lot of reasons for ankle arthritis, but ankle fractures is a big one. The other one I tell people too is with ankle instability that I see quite a bit in my practice, and this is even with young kids and older patients too. So with ankle instability, a lot of people, if you've sprained your ankle in the past, back in high school, anyone ever done that? Pretty common. So with ankle instability and spraining your ankles, it's one of those things where physical therapy obviously helps. And most people that have ankle sprains, we don't have to do a whole lot. We can kind of monitor them. We can put them in a boot and icing, and the classic rice where you rest, ice, and elevate. Most ankle sprains actually do really well. It's the repetitive ankle sprains that cause issues. So I have some patients that have kind of like really bad arthritis. And then if you ask them, like, do you sprain your ankle a lot back in high school? They're like, oh, I'd step on a pebble and sprain my ankle. It's very common. So the problem with the instability of the ankle joint, or if your ankle always wants to give out, it's kind of like when your alignment is off on your vehicle, the steering wheel starts shaking like ours usually does. So when your alignment is off, that causes the bone in your ankle joint to kind of tilt back and forth. And so that wear and tears your cartilage. And the problem with the cartilage in your ankle joint, the cartilage that you're born with, you'll never get that back. And so it can develop some scar tissue and arthritis. And so there's a lot of preventative things you can do about it. So I think the most important thing is if you do have ankle instability and you're concerned about ongoing pain or down the road, a lot of people kind of wait till the pain comes. You can always come in and have a visit, take some x-rays, because there's a lot of preventative things we can do. Physical therapy by far has been really beneficial for my patients. Exercising and doing ankle stability things that we can do to help control the ankle joint to avoid that rolling. Some people, I have patients where they don't have pain, but their ankle just constantly gives out. And so leading up to the ankle arthritis, a lot of the times when patients come to see me, we'll try a lot of bracing that you can do for this. Icing, anti-inflammatories can help with it, and physical therapy is a must for everybody. So on top of that, if people continue to not improve and they're getting worse, a lot of these people are tough patients and they can deal with the ankle pain for a while. So it can lead to what it's called is ankle replacement. So when I was trained during residency, we did a lot of ankle fusions. And so if you kind of imagine your ankle joint, taking your bones together and putting plates and actually fusing the joint together, trying to walk like that's rather difficult. But it's at that time what we typically did, and we used to fuse ankles quite often, but coming up with ankle replacements, the technology is really advanced lately. So it's a tough joint to fix because it's kind of like a knee replacement, but the joint in the ankle is a lot smaller and there's more added weight with the leg rather than just the whole body. So we want to try to avoid ankle replacements in patients, and we always have a saying that the older you are, the better you'll do, because ankle replacements can fail, just like knee replacements and hip replacements like that. So I just wanted to kind of talk about one thing that I did my fellowship in was joint replacements. So we'll actually have patients come in, and what we do for these ankle replacements is we'll actually do CT scans for these patients, and they go from the knee all the way down to the foot. And so with that, the CT scan will actually show the axis of where your knee and your ankle are, and we know where the best spot for that ankle is to be at. And so this technology is really advanced, so we order a specialized CT scan, and there's actually physicians and engineers that will design a specific ankle implant for the patient themselves. So I kind of have these little implants, kind of neat to show patients because I like to have something you can kind of like see what we'll do. So these are kind of like styrofoam sterilized implants. So this is actually one of my patients that I did. So the ankle joint, this is like the front of the leg on the tibia. So this would be right down here. And so what these scans do is it's actually really neat because you can have a deformity of the ankle. And so some people's ankle, and this is why it's important to come in and get x-rays if you've had chronic ankle sprains or chronic pain, because if that ankle joint starts tilting, it kind of keeps going. It's like a teeter-totter effect. Once it kind of tilts, it keeps going, and it makes you kind of a different candidate where you may have to do a fusion because the ankle joint tilts too much. So with these devices, it's actually pretty neat. When we get the CT scan, we actually have this in the operating room. So these come sterilized, and so this is actually a patient's tibia, the front of the ankle joint. And what they do, and I'll hand these around so you guys can kind of get an idea for it. So this is basically the cut guide for doing the joint replacement. So this guide right here actually, it's actually really reproducible. When you put it on the ankle joint, I'll have it in the operating room. I'll actually take this out, and it's sterilized, and so I put it right on front of this tibia, and I can actually outline where this should fit. And if you actually take this, and I'll hand this around, you can move it around, it almost clicks into place. And so then what you can do is I take this guide, make my marks on the bone here, then I go to the patient right in front of the ankle's all open. I put this device, and it has the same press fit on the patient's bone in the operating room. So this actually implant goes on the bone, and you'll see these 4 holes in this device. So you put wires down here, and then once that's secure, we take x-rays. And basically with that CT scan that we had done before, we can make sure all the lines and everything is perfectly matched. So it takes the guessing game out of a joint replacement. So it's very reproducible. It's actually made my job a lot easier. When I first started, we had to freehand cut these, and it's kind of nerve-wracking a little bit, because if you make a wrong cut, you kind of got to shave some more off and keep chasing the bump. So this actually takes the guessing game out of it. And so I'll hand this around. You can, oops, give that to you here. So when that guide goes on there, we can put basically now a metal guide that goes on top of it that fits in those wires sticking out of the tibia. And then we can make our cut in the bone so that's perfectly matched. And the neat thing about it is I've seen some really, really deformed ankles where the ankles are really tilted or there's a lot of arthritis there. And so this can actually correct, if you have an ankle joint that's tilting one direction or the other, we can actually use this cut guide to actually fix that deformity by taking a wedge off the opposite side. So it's actually really beneficial for it, and it just completely takes the guessing game out of the whole thing. So, and here's another piece. So this would be the bottom half of the ankle joint. So this would be the talus, that's this thing sitting right here. So this talus, and I kind of outlined it, so this one's a little bit more difficult to put on. So when you put this on, you can kind of feel that it's a nice press fit. Again, we do the same thing with this. We put the wires in here, and then we can make a perfect cut on the talus based off the patient's deformity or the level of the arthritis that needs to be removed. So once we have all the bone out and everything like that, we can put the implant in the ankle joint. And I think if you put yourself in this perspective or any family members with it, an ankle fusion is a very difficult thing to get through. I actually am very surprised that some of my patients that can be non-weight bearing for 6 to 8 weeks is pretty difficult. So a lot of these ankle fusions, you're not walking on the ankle for about 2 months. So it's really difficult because I have some patients where, like, imagine just laying in bed for 2 months. It kind of takes a toll on the body. And so with these ankle implants now, this has been probably one of my most satisfying things that I do in the operating room, because people almost instantly, they feel really like their pain is completely gone the next day. It's one thing that always happens. And I got complications with other surgeries and people have some pain post-operatively, but these ankle implants are really nice. So, and the good thing about that implant, once it's in, we can actually put, they're called poly spacers. We can put it in the ankle joint to make sure it feels nice and tight. If it feels a little bit loose, we can go up in size and make sure it fits the patient. So the benefit of this one is I do keep patients off their foot for a little while just to allow the sutures to heal up. So it's the incision right in front of the ankle joint, and we sew it up and give them about 2 to 3 weeks of staying off it, and then we can get them walking. So basically from 10 to 12 weeks of not walking to getting people to walk in about 3 weeks. So any questions about total ankles? I know it's kind of a lot thrown at you, but the technology's changed quite a bit, and just something that I wanted to kind of bring up today. So if you guys have any questions about that.
Can we go way back to what causes arthritis?
Yeah, well, yeah, exactly. So I think a big one would be ankle sprains, probably the most common that causes arthritis. A lot of the issues too with foot deformity. So some people have really flat feet, or they have a high arched foot. So it's kind of tough because a foot deformity, like a flat foot, it can cause pain in certain different spots. And this is the hard part. And, you know, the flat foot is the next topic that we could talk about as well. But every person has a different kind of foot deformity. So it's pretty rare. Like, we know what a normal foot looks like, but it's pretty rare to see that normal foot. And so when you get x-rays, the neat thing about the x-rays is that we can actually measure certain angles and degrees of what normal should be like. And then with these certain deformities, like a high arched foot or a really flat foot, you can kind of predict where patients are gonna have pain. So I can walk into a clinical room and I'll see a patient with a flat foot, and they have a hard time explaining where their pain where their pain is at. And I can take my thumb and push right where I think they're gonna hurt it, and it's usually pretty reproducible. So with the arthritis, if you do have a deformity where it's flattening, it just puts abnormal pressure on different joints. And so the abnormal pressure kind of shears those joints and kind of slowly wears and tears some of that cartilage. So, but a lot of times too with arthritis, I've seen some bone-on-bone arthritis and patients have no pain. So that's why I kind of run that home with a lot of patients. Like, I don't treat x-rays. You can have bone-on-bone arthritis and you can see the arthritis on the patient's big toe joint, and you can ask them if they have any pain, if they don't have anything. It's just one of those things where if it doesn't hurt, you don't have to address it. You don't have to fix it. You don't have to do surgery with it. Just kind of monitor the pain. So if you do get a flare-up, again, that's the way I always tell a lot of patients, just kind of slow down your steps in the day. It's hard to be non-weight bearing, so I always tell people, if you can cut half your steps down in a day, that's kind of what you should do for that. So again, ice it, rest it. But the hard thing with our arthritis is hard to reverse it. You can't, there's not a whole lot to do with that, but if you can capture things early and say, hey, you got a flat foot deformity, we can try some custom orthotics and kind of re-support the arch and help with preventing or slowing down the rate of arthritis. So, yeah.
How do you know if you're just having an injury or pain, or if you have arthritis?
Say that one more time.
How do you know if you just have an injury or pain, or if you have arthritis that needs to be treated?
Well, I think a lot of the times too, if you have like a deformity, And it's pretty straightforward to figure out if you had an injury. You're right, you went for a long hike or anything like that, but I think a lot of times people don't know what's going on with their pain. So if they go on a long hike, I had a patient today went on a long hike and ankle was swollen on the inside, and so they thought it was from the hike, but the patient had a flat foot deformity, and so the deformity, and that's kind of like why some people get a knee replacement at 65 on one, and then at 70, 5 years later, it hurts on the left, and then they have to do a knee replacement on that on the other side. So if you catch these deformities, you can't reverse it without surgery, but you can actually support it with inserts or bracing or casts or anything like that, just to kind of like help support the part of the foot where it's actually deforming and collapsing. So that's a tough one with the arthritis. I mean, most of the time with the arthritis, again, end stage arthritis, where it's like bone on bone arthritis, it's pretty easy to see on the x-ray, but there are other things that you can catch where it's not just the bone on bone arthritis that's causing pain, but you can actually get cracks in the cartilage, where some of the lubrication in the joint gets into the bone and can cause a lot of pain. So a lot of that, just seeing if you do have pain, it's better one of those things to like come in and be assessed by it rather than waiting for it to get worse, because a lot of things are easily treatable. Yeah.
What are the various nerve disturbances?
What's that?
What are the various nerve disturbances? I'm assuming that some of the issues with our feet are nerve changes, pinches, growths that cause foot pain.
Oh, so like.
So if there's, if this were my foot and I push there behind that toe,
Yeah.
there's pain there.
Yep.
Not always. Goes away.
Between your third and fourth toes.
Yeah.
Yeah. Yeah, that's
Which toe is?
Yeah. Yeah, that's a very common one. So that's called a Morton's neuroma. So it's interesting about that one. It's the only spot on the bottom of the foot where there's one nerve that comes off on the bottom of the foot, and all those nerves branch out to provide innervation or kind of like function to the toe on each side. I'm assuming between the third and fourth toe, there's two nerves that actually join together. It's the only spot in the foot that it happens, and those two nerves join together. And it's kind of like a bottleneck going on the interstate. So basically getting off the exit. Yep. So all the traffic's coming in, it joins together. So that nerve inherently is a little bit bigger on everybody. And so that nerve is supposed to be there. But again, certain activities, shoe gear, trauma, you can step on a rock and irritate that nerve, and then the problem, there's so much anatomy in the front of the foot there that now that nerve gets irritated, gets rubbed on between the bones, so that can cause, that's just one of them, but I'm assuming that's what you're talking about on that, so.
I don't know. It's so those kinds of issues are fixable by surgery. Just pay attention to your foot gear. Are there exercises?
I think most of the stuff that I take care of besides trauma, there's a lot of things you can do conservatively. I think the hardest part for me is that treating certain patients, I can do one thing for one patient and say, hey, you should try this shoe, and they come back like everything is great. And I can say the same thing to the next patient and like didn't help at all. So I think the majority of things that I do for my practice is I try to find as many things as I can that will help the patient, but it only works about 60% of the time. So again, it doesn't matter which one it is, as long as we get you feeling better. That's the key. So I think a lot of things you can do. Shoe gear is very important. Again, the hardest part is, which shoes do you buy? And so I think I usually don't tell brand names because there's so many different new brands, I can't even keep up with them. And so what you can do though is take a shoe. If you can take a shoe and bend it in the middle of the shoe, it's probably not the most supportive shoe. So you want the one that's a little bit more rigid right in the middle of the shoe. So if you can take like, hey dudes, you can actually fold in half, put them in your pocket, probably not the best shoe. But then the problem is I have people that wear hey dudes, it's the only thing that helps them. So, but that's why I say majority of the time, time, I offer that for patients and kind of do that. So again, a lot of times with conservative treatment that I talk about with patients, I go through quite a bit of things with them. And again, it's not so much like icing always works, or anti-inflammatories are always work. And I, some patients with steroid injections, I mean, I look like a hero. Sometimes I give an injection, they come back, they have zero pain. And then the next patient, do it a steroid injection, didn't help at all. So I think just offering as much conservative treatment as possible. And so that's why, you talk to other friends or family members that may have had something done, or like a neuroma that we were talking about with that nerve. Some people say, I had a steroid injection, didn't work for me at all. Or I tried this insert, it didn't work for me at all. But the thing is, there's so many other patients where it does work for them. So I usually offer as many things that I have found in my practice that helps those patients, and hopefully a number of those help out. Yeah. So, yeah. Any other questions on that? Appreciate the question. Yeah. Another one too is in terms of the flat feet. I see a lot of pediatric flat feet. So I think that's an important one for parents, I think, more than anything. My nephew actually had flat feet and had surgery too. And so it's one of those things where it's near and dear to my heart. And our residency program when I was in Pittsburgh, we did a lot of flat foot surgery in pediatrics and older patients. And so I think a good topic to talk about is for pediatric flat feet. It's pretty normal that you'll see, like we got a 3-year-old and he's got some flat feet right now. It's pretty normal. So between the ages of 0 and 7, the feet will actually rotate, go from like a flat foot to a neutral foot to kind of like tipping over on the outside. And the foot will rotate because as the bones grow in a kid, the bones will actually rotate. And so it changes the foot, and the foot has to catch up with it. So especially if there's grandkids that have flat feet, a lot of times a 3-year-old's not going to come up to you and say my feet hurt because they're flat. So I always educate, usually when my kid probably will, right? But I think the appointments that I have with parents and young kids is, I think the most important thing is education. A lot of kids that have flat feet, they don't know how to tell their parents that they hurt, and so a lot of times it's monitoring the kids, like, hey, are they not participating in sports? Do they prefer to play video games and not go for a run, or hate gym class because of it? Because they associate with all activities with pain. Imagine being born with that flat foot and it always causes pain with physical activity. So they may like basketball, but they don't because it's associated with pain. So I always educate the parents on that, to keep an eye on the kids. A lot of times, most parents will say, yeah, every time we go for a hike or go for a long walk, they're always last. They're always way behind us. And so I kind of tell them, I'm defending the kids too. It's like, it's not that they're lazy or want to just be the last one in line. It's just because it's extremely painful for them. So we have kind of in my practice, what I do, custom orthotics are a big play with treatment for this. I recommend all pediatric patients with flat feet just come on in and have it evaluated. Most of the time they have no pain, it's asymptomatic. But with flat feet, I always recommend after the age of 7, that if it becomes painful, that's when you start considering orthotics for the kid, because you don't want to interrupt the way the foot and the leg are growing as the kid is growing, because we just want to let it do its own course. And so, but when kids become symptomatic, it's quite painful. I've had a few kids coming in crying, just walking to school, walking to classes, and so it's very painful. So, the first visit with the patient and the parents, if they're older than the age of 7, we get x-rays and we see how bad and how severe the flat foot deformity is. And the first thing we always do is custom orthotics or over-the-counter inserts, because they can get expensive. Well, custom orthotics can cost up to $400 and they're very expensive. And unfortunately, with insurance companies, they're getting good at not paying for things. And so it's out of pocket a lot of times. But, and again, it's the same concept too with basically any deformity or any bunion or hammer toe or flat foot that people can have. You'll get these flare-ups where it's very painful. It doesn't mean you have to go and fix it. You can just go through the whole process again and decrease in activity, physical therapy, icing, anti-inflammatories, the typical conservative treatment, and then kind of slowly get people going on. It's just the chronic patients where you've done that, and it's no matter what they do, it's chronically painful. So there's two different types of ways if people have tried and failed all conservative treatment with flat feet. With pediatrics, there's a joint sparing and a joint destructive type of surgery that we do. For pediatrics, the goal is to save the joints as long as possible, because we want kids to have full functionality with their foot. And so there's a few options that we can do for it. And even in surgery, there's not like a flat foot surgery that we do. Every foot is completely different. So you have to analyze the foot. Some people have a deformity in the back or the front or the midfoot. So it really changes the whole process of it. So every foot it's not like, oh, you get flat foot surgery and it's the same type of surgery. Every patient is unique, and their foot is unique. And, there's 26 bones in the foot. Every bone has at least one joint. Some have up to 4, so it's a very complex foot. Everyone has different deformities in different spots. So kind of talking about the arthritis as well, again, that with the flat feet, again, if they're asymptomatic, we don't typically treat them. But when people get into adulthood, I do recommend that if you have flat feet, I highly recommend custom orthotics, because the custom orthotics won't correct your flat feet, but they'll definitely maintain its position, and it can slow the progression down. So with bunions, with flat feet, typically with it progresses and it worsens more and more with time. So, question?
Oh, I have a question.
Yeah.
My grandson is 5, and he has a friend. Thank you. He has a friend who walks around on his tiptoes.
Yeah.
What is the cause of that?
Yeah. I'm sorry. Yeah, so I think some kids just like walking on their tiptoes. There's a few things, I've seen quite a bit of that. The first thing I do is I ask the kid just to stand on their tiptoes and then get their heels down. So if they can get their heels down, I'm not too worried about it. A lot of people, or a lot of kids do grow out of it and they stop doing it. But some kids will do that because it's the least amount of painful position to be in. So when I do flat foot consults with parents, the number one thing that I always see with flat foot is they have a tight Achilles tendon. So their calf muscle is really tight. And so when kids walk on their tiptoes, if they can keep that calf from being stretched out, it provides a lot of pain relief for them. So it's actually a comfort thing because it avoids the pain of it. So that can be a surgical issue. We try to avoid doing surgery in kids that young. I think the youngest I've ever done was 9. Because of flat foot deformity and the tight calf muscle is so painful. But it's pretty common that kids with flat feet always have tight calf muscles, in my opinion. A lot of times you'll see those kids, there's 2 ways to compensate when you have a really tight calf muscle. One is to walk on your tiptoes, and the other one is to kick your feet way out. So you're kind of walking like this. So that kind of gets rid of the tight calf muscle. If they don't compensate that way, the tight calf muscle, when they start standing, it causes the kind of the arch of the foot to collapse, and the foot wants to actually splay out. And so that's where the flat foot deformity comes from. So that is something that we do. Physical therapy for that works really well. We've even done Botox with that to help out, stretch out the calf muscle just to relax the muscles. But some of those kids, when they're that severe, if it is a painful thing, when they're walking on their tiptoes, can be a surgical problem. Yeah. So you can actually lengthen out the calf muscle pretty easy, and then you can cast them for a little bit just to maintain that correction where you stretch out that calf muscle. So, yeah.
As far as pronation,
Yep.
is there something other than orthotics that you can do to help prevent that?
That's a tough one. Yeah. So she said, with pronation, is there anything else you can do besides orthotics? Pronation is a flat foot. That's a tough one. In my opinion, there's not a whole lot you can do to prevent it. Once it kind of goes, once a body has a flat foot deformity, you usually always have it. And so the goal is to treat the symptoms. So again, if you have a flat foot and you have 0 pain, I don't really recommend doing a whole lot with it besides the custom orthotics just to help maintain it. And again, it's the same. This is the main thing I see all the time. It's like, if you have a really bad deformity or a really bad flat foot and it's very painful the first few days, again, you kind of repeat the process like, all right, let's get this acute pain to go away to see if when you're walking in the future, you're fine. Because again, I ask a lot of people too is, did you have pain 6 months ago? And a lot of times they say no. It's only been like 4 weeks. Well, you had a flat foot 6 months ago and you were pain-free. So if you can get rid of that pain, then keep on going. But the orthotics definitely is probably the best thing you can do for it. You know, physical therapy, I don't really do a whole lot of physical therapy with flat foot because it's never gonna really re-correct the arch. It's kind of like once you have it, you have it. Yeah, so, yeah. Yeah. Any other questions? Yeah.
What causes nodules, or what causes nodules or feeling like there's little stones in your foot?
Like in the arch?
Yeah.
Yeah. So there's a lot of soft tissue masses that we come across. Most commonly right in the bottom of the foot, use my awesome looking model here. The plantar fascia, we've all heard of plantar fasciitis. It's a very common thing that we see. So the plantar fasciitis, or the fascia, goes from the heel all the way to the front of the foot. And so it kind of really supports the bottom of the foot. Problem is you can get some scar tissue down there that can be some of those little nodules. A lot of times they're called fibromas. They're actually extremely painful. And it's basically basically when you get tearing of the tissue down there, you can get a lot of scar tissue. And so again, a lot of those, a lot of my patients that I see, they actually don't have a lot of pain with it. They just want to know what the lump on the bottom of their foot is. And so 9 times out of 10, it's a plantar fibroma. But any soft tissue mass in the foot, bottom or top, I usually always get an MRI for that, just because it's a soft tissue mass. You know, I'd be concerned, patients are concerned about masses because there's always the cancer thing, but cancer is pretty rare in the foot. So, but I still always get the MRI because I think it gives patients kind of a sense of relief. We know what it is. If it doesn't hurt, we don't have to do anything about it. A lot of times with the foot, any kind of soft tissue masses, if it doesn't hurt, I tell people keep doing what you want to do. The moment you start feeling pain, finding the right shoes, orthotics to offload the area, and then if it still hurts, there's other modalities you can do. Steroid injections can decrease the mass depending on what it is. A lot of the times you can just remove them though too. So, yeah, yep. Keep these questions coming. This is great.
Okay, so bottom line, most people aren't going to go to the podiatrist. How are we supposed to, what are the best ways to keep our feet healthy so we don't have to come see you? Tell me what kind of foot love I need to do, okay? Yoga, massage, pedicure, whatever.
Yeah.
Bottom line.
I see the extremes of everything. Some people just want to be pain-free, but then there's people that want to be very proactive with their foot or their feet. When I was in Pittsburgh for a while ago now, barefoot running was a big thing. Do you guys remember that? The problem with barefoot running in the middle of Pittsburgh downtown is probably not the safest thing for your feet. So there was a lot of foreign bodies that were removed during that year. But I do believe in that, particularly with kids too. A lot of parents have a lot of questions about, should I keep my kids in shoes? My thing is keep them out of shoes as long as you can. Let them run around, gain foot strength. I think the reason why a lot of people have foot pain is the moment you go into shoes, your feet inherently weaken. Because now you're not relying on supporting the arch of your foot, you're relying on the shoe to support it. And so, again, if you took an x-ray with your tennis shoes on, high heels, gives you bunions. It pushes it in on the x-ray. When you take the shoe off, the toe will straighten out. But a lot of the shoes can actually promote a lot of that. So a lot of people do the barefoot stuff or the minimalistic shoes. My advice on that is to be very careful with it, though, because we've been walking on shoes our entire lives mainly. And then people just 100% go all into barefoot walking or barefoot minimalistic shoes. You want to do it nice and slow, because a lot of stress fractures, that's the most common thing with that, is stress fractures. Doing something too much too soon causes a lot of pain with it. So, I think that it's just pretty rare to see people doing workouts with their feet. But you definitely can. There are exercises that you can do with it, stability exercises for it. You do a workout at home with your feet, yeah. My wife sees me doing that all the time, just like bunion push-ups or something. But yeah, I think just wearing I think the most important thing is wearing the right shoes. And if you do have concern about anything, because I would say most people have something wrong with their foot. I can take an x-ray and I can always find something wrong. Again, if it doesn't hurt, don't do anything about it, but it's good to have an idea of like what could progress, things you can do to help offload it, prevent the pain too. So, but yeah, strengthening, big one. Yeah, absolutely. I think the biggest thing is stability. That's where a lot of people have problems with, is the rolling their ankles. We live up in the mountains now, so going on trail hiking and stuff like that. So there's a lot of things you can do to support the ankle and the stability. It's pretty rare to find people wanting to do that though. Yeah.
Okay, so there's this one. I'm going to shut it completely off. There is this, she's a doctor of some sort, where now she's talking about jumping like 20 times a day.
Oh yeah.
Right, so not only should we be taking protein and creatine and lifting heavy and trying to be nice, but we should also jump up and down 20 times a day because it promotes bone health.
Yeah.
Are these the exercises you're talking about for your ankles? Or is that helpful? Is this real?
I think jumping is a good thing. I do. Trampoline stuff. I do. No, I think having force, especially as we age too, I think that's really, particularly in females, doing resistance training, and I think jumping is a good thing, but you just don't want to jump into it too much too soon. That's where most of the problems that I see with patients, they do something way too fast and then they have the problem. So, come January, everyone has a New Year's resolution, people just flood in February with new pain because they did something too much too soon. So I like the jumping stuff. I think the impact, it forces bone to grow because now it's bearing more weight than it typically does, so that you can strengthen your foot that way. I would just maybe start with a couple bunny hops and work your way up to the pogus, just jumping on that. But yeah, again, I think there's a lot of benefit to that with lymphatic pumping and stuff like that too, but keeping those joints moving and putting them in stress like that is a good thing.
So it's real?
Yes,
okay.
I have seen it.
Nice.
I don't promote it in my clinic.
I was hopping around the house thinking, this better be real, right?
Yeah. Yeah, my doctor told me with my bunny, just do some bunny hops for a while. Yeah. Any questions about anything else? Anything random?
I spend a lot of time walking backwards.
Yeah.
And jogging backwards.
Yeah, that's great.
I've been doing that for probably 50-some years.
Wow.
Jogging backwards?
Yeah.
All the time?
Not all the time, no, because I'll pivot around. I can do that. You just keep going backwards and just glance, see what's behind me.
Yeah.
And then I'll just do a little hop.
Yeah.
Straight in.
Yeah. I actually completely agree with that. I'm not an orthopedic surgeon, so I don't do knees, but I did have some knee issues, and I think a lot of times is, we were taught in school when you do squats to not let your knees go past your toes. And again, this is not my area of expertise, but a lot of the stuff that I've been doing now, I've been actually letting my knee go past my toes to strengthen it. And a lot of the ones I have done is walking, don't make fun of me, walking backwards on a treadmill when it's turned off actually will strengthen the quads and stabilize the knee. So yeah, I think that's, yep, I agree with it. Yep. Yeah. Yep. Yeah, absolutely. Yep. Yeah. Just add some hops into there now. Yeah. Yeah.
I have a question when you go to the rheumatologist and your choices are, we're going to fuse it for cortisone shots, and if you don't tolerate those, we'll just fuse it, but aren't you going to lose a bunch of mobility?
Yeah.
And what is the purpose of that? What does it really fix, or is it just one more surgery they get to do to you?
Yeah. I think rheumatology patients they're tough. It really affects the joint with the autoimmune disease. So basically with that, it really attacks the sides of the joint that destabilizes the joint. So It causes a lot of hammer toes, causes bunion deformities. But whenever you lose that stability with rheumatoid arthritis, that affects the smaller joints. It really destabilizes it, and the destabilization, that's what causes arthritis. Kind of like the analogy I was using, when your alignment is off and your steering wheel is shaking, those tires are going to wear out a lot faster as opposed to having your alignment perfect, steering wheel not shaking, tires rotating well. So it's the instability of that autoimmune disease that really affects those joints. So that's the hard thing. And again, it's tough because you can see those joints kind of wear and tear with it. Especially in the foot, there's not a whole lot to do with that. The biggest thing is just to help prevent the pain. Again, orthotics is a great idea for that too. Just to, again, all my rheumatoid patients, I always recommend custom orthotics, even if they don't hurt, because with that, they kind of get fat pad atrophy on the bottom of their foot. Their joints are a little bit more unstable. And again, when they get hammer toes, it really causes the bones to be pushed down on the bottom. So a lot of my rheumatoid patients, I mean, it's skin and bone on the bottom, and it's extremely painful. So a fusion is one of those things. One, it gets rid of the arthritis, gets rid of the pain. Unfortunately, you lose motion with that. So the problem with rheumatoid arthritis, if that joint is so bad, it's the movement that hurts. So that's kind of why I don't have arthritis right here, because there's no joint. So if you fuse those two bones together, then there's no joint, and that's what relieves some of the pain. Yeah. Awesome. Okay. Well, thank you all for coming out and listening. If you guys have any other questions, feel free to talk to me after if you have, or feel free to stop by. But I think the biggest thing I can tell you is kind of don't wait on things. There's a lot of things we can do preventative. We have a lot of conservative treatment options that are available. And the biggest thing too is just because one thing didn't work for a friend for the same diagnosis you may have, it might actually work for you. So I think getting some advice coming in and seeing where you're at, I think it's a good thing to be proactive, because there's stepwise, sometimes the longer you wait, then the worse it can get and the harder it is to address it. So don't be shy to see us. Yeah.
Well, thank you all for all of your thoughtful questions tonight.
Thanks.